Thank you, Bala, for this kind introduction. And thank you for making me part of this IC. I think congratulations to you for a very well conceptualized IC. The topics are catchy and very, I think, learning, and especially on the last day to see all of you here, it's very nice. So, coming on to my topic in this IC, not sure of infectious or inflammatory, how do I tackle in dicey situations of uveitis? Now, before we move on, just a word about the differences between the two, infection versus inflammation. So, infection is caused by invasion of the body cells by any pathogen, and inflammation is the body's response to any kind of biological insult, whether it's infection or injury or anything. So, infection is not always present with inflammation. However, inflammation is always present with infection. So whenever you have infection, you have to have inflammation, but whenever you have inflammation, it's not necessary that you have infection. So first case I'll show you and try to bring about some differences. We had this 43-year-old male, a known case of cutaneous malignant melanoma, having received 3 cycles of chemotherapy. So he was an immunosuppressed individual, presenting with sudden onset loss of vision in both the eyes, more in the left and more than the right eye. So this is how his eyes looked like. The right eye was having hand motions vision and the left eye had just light perception. Now if you look at the clinical presentation of both the eyes, they are similar but they are very different. They're similar in the terms that there is hypopyon in the right eye, there is also fibrin in the right eye. The left eye also has hypopyon. The pupil is not dilating. So the similarity is both the eyes have hypopyon, but the gross difference which is very striking is there's so much of adnexal reaction in the left eye. It's not so in the right eye. So right eye is like a hypopyon fibrinous uveitis and left eye is much more than that. There is chemosis, there is lid edema and partial restriction of the eyeball movements. Now if you have to have a differential, you really don't know what's going on. If you look at the right eye, probably a case of an endogenous endophthalmitis, right? Because we are not able to see the fundus in the right eye, just the glow. Now if you look at the left eye, is it a panophthalmitis? Is it a non-inflammatory lesion? Because so much of adnexal reaction, mind it, it's never a part of an endogenous endophthalmitis. So if you have so much of adnexal reaction, either it is pointing towards exogenous endophthalmitis, a history of trauma or surgery which is not there. So we were lost. More so this case posed us a challenge because this guy presented to us on a Saturday evening when your hospital services are shutting down, your laboratories are shutting down and you really don't know what to do. So now the question is, do we go in for the right eye? Do we go in for the left eye? Right eye is a little better. Obviously you can see and even the vision is better. So should we intervene in the left eye? So what do we do? If we go in the right eye, do we do a pars plana vitrectomy, considering it as endogenous endophthalmitis? Or if we go into the left eye, do we do an AC tap? Because doing a vitrectomy in the left eye is out of question. With so much of reaction, you don't know what you're dealing with. So we thought we have to save one of the eyes, and we were quite blinded by what's going on. So we took up this patient for a right eye vitrectomy, counseled the patient that we think that your right eye is salvageable. We really don't know what we are going to do with the left eye, so at least try to save one of your eyes and try to give you vision. So we did a pars plana vitrectomy in the right eye with intravitreal antibiotics. You can see 3 days post PPV, the pupil is better dilated, the fibrin is gone, of course he's on topicals also, and the hypopyon is gone, and we now start seeing the media. So this disc is visible almost media grade 3 and we are seeing some exudates inferiorly. Obviously we did a core vitrectomy, it's not possible to clear the entire vitreous. So we are little having a sigh of relief that yes, and the patient is now seeing about 3 meters. So he's from hand motions to 2 to 3 meters. So we're a little better off, but we still don't know. Now all the reports of the vitreous sample were again negative in this. Now we left the left eye, we didn't know, we got the CT done to see what's going on the orbit. There was just diffuse inflammation in the orbit. Our oculoplastic specialist also were not able to comment on what's going on. So since we left the left eye, and one point is that one should never intervene in an eye because when you don't know what you're going to offer to the patient, I think stay back, because just for the sake of doing something, when you're not able to do anything, you don't even know what you're going to offer to the patient, I generally hold back. And we counsel the patient that we really don't know what's going on. So we left the left eye like this, and you can see with the IV antibiotics, his chemosis and adnexal reaction is going down. Obviously, the corneal clarity is going down. We are losing this eye. So he was no PL, but by that time we had got the CT done and the PET CT done, because he was a known case of malignant melanoma. So PET CT was high on our mind, and we got it on. It's not easy to get a PET CT in an emergency, because we have patients dated for months in our PET CT department. So we had to get this PET CT done on a very emergency basis, and it showed that there was an increased FDG uptake among the cutaneous parts, liver and lung lesions, and left choroidal lesion. So there was an increased uptake in the left choroid, and that was suggestive of a metastatic lesion in the left choroid, and that manifested the entire inflammatory reaction in the left in the form of hypopyon and adnexal reaction, because there was skin metastasis also. So this is the final outcome of the left eye, which we did not touch. And this is the 3 months outcome of the right eye. He's seeing counting fingers 3 meters, and he's mobile. So this is what he started with, and this is what he became. At least cosmetically, we could save the left eye, and we could give him the vision in the right eye. So this case taught us the difference between an infection and an inflammation, and we realized that the infection was more urgent to treat with. If you intervene in time, you can at least visually rehabilitate the patient. And when there is so much of inflammatory reaction, as we saw in the left eye, and we didn't know what it was till we got the PET CT done, so we left it alone. Anyway, it was a blind eye almost to begin with. Now, when we talk about infection versus inflammation, any of the clinical signs, I don't think there is any clinical sign which would just tell you it's infection or it's inflammation. But I would like to highlight 2 clinical signs, one in the anterior uveitis and one in the posterior uveitis, which can tell you, if you examine clearly, that there is an infection or there is an inflammation. For example, when it comes to anterior uveitis, hypopyon. When you see hypopyon, you may jump to a clinical etiology of an infectious uveitis, but we need to see carefully. Now look at these 2 different pictures. The one on the left, you can see a red eye. You can see fibrin in the anterior chamber. The pupil is not dilating, and there are lots of posterior synecdoche. On the right, again there is fibrin in the eye, but the eye is cold, there is no congestion. Pupil is very well dilating. There is not much clinical sign except fibrin in the anterior chamber, no posterior synecdoche. They look quite different, and they are different. One is a case of acute anterior uveitis, HLA-B27 positive, the other is Behçet's disease. But the similarity between the 2 is both are inflammatory autoimmune diseases. So here we are not encountering infection. On the other hand, similarly, if not fibrin, let's see a case of hypopyon. The one on the left, same findings, congested red eye, non-dilating pupil, posterior synecdoche. The one on the right, you can see a streak hypopyon. On the one on the right, cold eye, fully dilating pupil, no posterior synecdoche, a streak hypopyon. Again, both are inflammatory. Another example, now different situation. The one on the left again has a hypopyon, no posterior synecdoche, fully dilating pupil, quite similar to the one on the right. So do you see any differences between the 2? Okay, a convex nature of the hypopyon on the right. Anything else? So we may not pay much attention to it, because here you are comparing the 2 eyes, but when you see clinically this patient, you don't have a comparison there. So both are hypopyon, both are fully dilating pupil, no fibrin in the pupillary area, no posterior synecdoche. But let's dilate these eyes and see there is no glow. There's only a glow on the left side. We don't see the fundus. On the right, we are fully able to see fundus and even do a fluorescein angiography. So what do you think it is? So we are dealing with an endogenous endophthalmitis on the left side, and we're dealing with the Behçet's uveitis on the right side. So this is where the difference between the infectious and the inflammatory etiologies come. So if we have this confusing sign of hypopyon, I think we can make our diagnosis and jump to the at least etiology, whether it's infectious or inflammatory. So second case, again continuing with the hypopyon. We had this young male presenting with fibrinous uveitis, hypopyon, lot of fibrin. Pupil is not really dilating beyond this. And you can see the first differential, because he was a young male, first differential was acute anterior uveitis. There was no other history except decreased vision. The second was an endogenous endophthalmitis, but he didn't have any history of predisposing factors. And the third was Behçet's disease, but Behçet's disease was unlikely because this was an acutely inflamed eye and the fundus was not seen. In Behçet's, however dense your vitritis is, at least we are able to see the fundus. So here we could not see the fundus, so obviously we went for an ultrasound. Now the ultrasound showed so much of exudates in the posterior segment that we ruled out acute anterior uveitis. So now we are having one possibility of endogenous endophthalmitis. He did not have any history, and when we were doing the ultrasound carefully, we found there was a retained intraocular foreign body. He did not give any history of trauma, nothing. We went back to the patient, saw him again on slit lamp, and we found this conjunctival tear. On coaxing again, he did give a history of trivial trauma, and here we revised our diagnosis to retained intraocular foreign body with a post-traumatic exogenous endophthalmitis. So this is where you can come to your conclusion by carefully examining the sign and then following up with the relative imaging. The second sign which I said in posterior uveitis is confusing is choroiditis versus retinitis. So as a rule, generally, if you see choroiditis, we are dealing with a non-infectious etiology, and if you see a retinitis, we are dealing with an infectious etiology. Unless the retinitis is of Behçet's, but mind it, retinitis of Behçet's is usually not a very large lesion. These are small retinal infiltrates which keep coming and going even if you don't treat them. So a retinitis of Behçet's disease is not really a challenge, but when you see these kind of lesions, the first one is a granuloma, tubercular granuloma, very typical of TB. You do an OCT and you see this kind of bumping of the retina and the choroid complex. The second one in the middle is a sarcoid granuloma, which is deeper in the stroma. Again, you can pick it up on the OCT. And the third one is simply a retinitis, which you again pick it up on the OCT as the retinal layers being involved. So this is how we differentiate between an infectious and a non-infectious cause when it comes to choroiditis and retinitis. So to make this difference is very critical in our uveitis practice, because appropriately we have to start treatment, and you have seen mishaps on treating infectious uveitis with steroids alone. So identify the clinical clues, which are not really difficult if you are meticulous in examination. Act aggressively when it's an infectious cause, but of course with great caution. Thank you very much.
Rima, I just wanted to make comments. It's not very unusual to get hypopyon due to the tumor. We have seen the retinoblastoma, adenocarcinoma of the lung can produce hypopyon. But in case of leukemia, I think leukemia comes first and then hypopyon comes later. I've not seen a case where the hypopyon is the initial manifestations of leukemia. Most of the cases are diagnosed, but if you are taking a step from the anterior chamber in a hypopyon, it's wiser to make a direct smear also. The cytologist can make it, the pathologist can look at the cells, even if it is not malignancy. He can look at the polymorphonuclear leukocytes, which will be abundant in infective etiology. And then if you see the lymphocytes and histiocytes or lens-laden macrophages, that gives rise to the granulomatous pathology like lens-induced uveitis. And if we see malignant cells like lymphoma, metastatic cells, which can be very easily picked up on cytology. Retinitis due to the Behçet's is not that very big retinitis patch. It's a small retinal infiltrate we see over there.